Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Hi, and welcome to the GRACE Supportive Care webinar series. My name is Arjun Gupta. Today, we are joined by Dr. Richard Dunne, who is a faculty member at the University of Rochester Medical Center in New York. He specializes in the treatment of GI or gastrointestinal cancers with a special focus on cachexia, which is the focus of our discussion today. Welcome, Dr. Dunne.
Good to be with you.
So to begin, can you tell our listeners what you mean by when you say cachexia and how this is related to or different from sort of other similar terms like anorexia, malnutrition, weight loss?
This is a great question. It's been a challenge in this field over the last few decades. As you alluded to, there are many terms that are used to describe either nutritional or metabolic deficiencies in patients with cancer. And I firmly believe that a lack of some sort of consensus definition and diagnostic criteria in many ways in terms of trying to make therapeutic advances. In 2011, a consensus group of experts got together to define and classify cancer cachexia, and they defined it as a depletion of muscle mass or fat mass that cannot be fully reversed by nutritional supplementation alone. So what this is alluding to is just by trying to replace nutrition, such as placing a feeding tube or artificial feeding or nutritional supplements, will not fix this condition alone. Along with this syndrome, it's very common that patients have impairments in their daily function, that they have a reduction in their physical performance, like unable to exercise, carry out daily activities like walking through the grocery store. And unfortunately, all of this is tied to worse outcomes and a poorer survival. And so this is a very important syndrome that is understudied but has gotten more attention lately. And it's critical that we make improvements in treating this so that we can help people live longer and improve the quality of survivorship for those who suffer from this condition but are receiving treatment and living on.
Wow, even I didn't know that. And is this term cachexia specific to patients with cancer, or can say other chronic conditions also lead to cachexia?
Yeah, I mean, I think you'll hear people when they refer to patients with cancer calling it cancer cachexia because it can apply to other disease states. So specifically, patients who have chronic obstructive pulmonary disease or COPD, emphysema, it's common that they have muscle wasting or cachexia. Patients who suffer from the HIV and AIDS can suffer from cachexia. And so this is different from the other term that people might have heard is sarcopenia. Sarcopenia is a loss of muscle that can be part of normal aging or part of how the body reacts to inactivity. So sarcopenia is not necessarily tied with any disease, but could be seen in patients with cancer. But cachexia specifically, when that word is being used, it implies that there is a chronic illness that's going on, such as cancer, COPD, or acquired immunodeficiency syndrome, AIDS.
Okay, so why are cancer patients at risk of getting cachexia? Is this something related to the cancer itself or its therapy or things we don't know? Could you elaborate on that?
Yeah, all of the above, really. You know, the specific signaling that occurs throughout, one person who suffers from this is not fully explained, but it's thought to be a combination of things. Yes, we very much think that the cancer is a part of this. We know that pro-inflammatory, so inflammation signals are increased in patients with cancer who have this syndrome. So there may be an increase in inflammation from the cancer. The cancer also can change one's own metabolism. So we see an increase in what we call resting energy expenditure. So our body is essentially burning energy at higher rates when we have this condition. And so that paired with a pro-inflammatory environment, along with less appetite or reduced caloric intake, will contribute to weight loss and muscle loss. Additionally, a lot of our cancer treatments can indirectly and directly affect our muscle. Indirectly, the treatment can cause lack of appetite or nausea, and that nutritional deficiency will lead to this. But medications such as platinum chemotherapies can actually cause direct muscle damage that has been seen in mice studies and is presumed to be happening in humans as well.
Okay, so that's a great background. And now coming over to the clinical side, so you're in the GI oncology clinic and seeing a patient with, say, advanced gastric cancer or advanced pancreatic cancer. Are there certain buzzwords that you're looking for in the history when the patient is reporting his or her symptoms? Is there something on physical examination, labs, imaging that you're looking for to diagnose or evaluate cachexia clinically?
The most significant buzzwords are how you started the question. Having pancreatic cancer or gastric cancer, esophageal cancer, the upper GI cancers are what put people at the most risk for suffering from this condition. So upwards of 83% of patients with pancreatic cancer or gastric cancer can suffer cachexia through the lifetime of their illness. Lung cancer is another cancer that has a high incidence of cachexia in about 60%. So having cancer and then having certain types of cancer would put you more at risk. So we know that patients are even at risk for these conditions just walking through the door once we know what their diagnosis is. Once we meet them, taking a very good history and a physical exam can help identify patients with cachexia. Now, the identification of patients with cachexia is very important. We think that early recognition and early assessment, early intervention is likely will be more effective. If we're identifying this problem late in the disease course, it is likely irreversible. And so, the things that we look for in the history is, do you have a lack of appetite? Are you not eating as much? One of the most common things that could be identified is someone's weight. Has your weight changed? We, as oncologists, we know that we're checking weight at every visit because it's important for our dosing for chemotherapy. So that is one of the reasons we get people on the scale at every visit, but it is also a very key clue to how things are going. So appetite, weight, but also these measures that I mentioned before, physical performance and function. So someone saying, you know what, I just don't have the same get up and go that I used to. I used to walk around the block, but I could only get halfway around this time. I can't do the housework around the house that I used to be able to do. And so, there are some objective things that I talked about that we look at. There are some markers in the blood, like albumin, which is a measure of protein in the blood, a low red blood count. These couple of things that are part of routine labs for cancer patients are something that may also be clues. In terms of the physical exam, we're looking at weight it's not considered a vital sign, but for me, I do consider it. So that's part of my physical exam, is assessing the weight and assessing the body mass index, which is measurement of height and weight. And then looking for what we call muscle wasting. So people who might have, we call it temporal wasting, where we see changes at the temples of the head. And on a physical exam, when we may be seeing more bony structures, less fat, less muscle, are things that a physician would be looking at when evaluating a patient for this syndrome.
Perfect. So just to sort of recap, this is a disorder often seen in cancer patients, often in patients with pancreatic, gastric, esophageal cancer, also lung cancer, usually in advanced or metastatic stages, where patients are coming in saying, "Hey doc, I've lost weight, my appetite isn't as good, I'm sort of wasting away, and I'm having trouble with tasks that I was perhaps able to do a few weeks or months ago." And they're coming and reporting this to you, and you're sort of making your diagnosis of cancer-associated cachexia. And there's obviously some reversible aspects in this. So if someone's not eating or drinking well due to nausea, whether that be from the cancer itself or the chemotherapy, we can try to address that. If someone is unable to swallow due to radiation treatment for head and neck cancer, we can talk about alternate modes of nutrition, whether that be through a feeding tube or something else. But what are some specific treatments, whether those be drugs or non-drugs, that you may be thinking of administering for cachexia?
Great question. So you might, in some of your reading, might find that there are, it's mentioned that there are no effective treatments for this condition, or there's a lack of treatment for this condition. And what that's referring to is that there are no FDA-approved standard treatments for this. But that does not mean that in any one individual that there aren't things that we can do. So what that's more referring to is strategies that were tried in clinical trials that might not have worked in large populations of patients. But we know that on the individual level, tailoring interventions that maybe not necessarily are drugs, but are behaviors or consultations might improve these things that we discussed earlier. So I think one of the most important things is providing education on nutrition. So, in addition to potentially looking for content online in terms of, nutritional education, I think if patients have access to a dietitian either in their medical center, or if they're seeing a community oncology practice, if there is a hospital nearby that has dietitian services, I think that is probably one of the most important things that you can do for this condition. I can talk to you about healthy eating with cancer in the setting of trying to gain weight or gain muscle. In terms of appetite, there are certainly appetite stimulants. And although those might not have gotten FDA approval to treat cachexia specifically, I think there can be a role for things that treat appetite in patients where appetite is merely the problem. But if you remember, I started this by saying that this cannot be fully reversed by nutritional support. So trying to improve the appetite alone may not necessarily make significant gains. So I think learning on healthier eating, possibly stimulating the appetite, and then physical activity. So I'm a firm believer, and although we're studying this in early studies right now, that physical activity, resistance exercise, aerobic exercise can help this condition. We've shown in small studies that we're able to improve someone's physical performance and their function. In terms of gaining substantive muscle, I think physical activity will probably need to be combined with a nutritional intervention to really make significant gains. But I think increasing one's physical activity, along with the things I mentioned earlier, are good places to start. They're cheap, inexpensive strategies. and one that I think is accessible to all cancer patients.
Wonderful. Could you talk a little bit about some of the medications that are perhaps have been tried for the treatment of appetite stimulation and or cachexia? I see all the time on the floors that we're trying steroids, including anabolic steroids, and also marijuana in different forms. And if there's any data out there or how you think of these drugs and whether you are pro or against them in your routine practice.
I think there can be a role for steroids, and as a GI oncologist, I often have to use steroids periodically. One for nausea control from certain types of chemotherapy agents that we use, but also periodically to help stimulate appetite and energy. I think the long-term use of steroids probably will not be effective for this condition because we know that long-term use of steroids can actually lead to muscle loss and could lead to joint damage. But short bursts of steroids of 1 to 2 week courses can help stimulate one's appetite. That's something that's hard to measure in clinical trials, doing this for short periods of time and the gains that it may receive. But again, I think just stimulating the appetite oftentimes is not enough. But I do think there could be a role in certain patients who are struggling maybe with nausea, that it's affecting their appetite, to use steroids. But in terms of sort of long-term usage or months worth of treatment of steroids, I think there are too many side effects and downsides for this to be a standard practice. Another agent that's been used in clinical trials in the past is something called Megace or Magestrol. And that has shown to improve weight, improve appetite. However, we know it has a black box warning of possibly increasing blood clots. And patients who have GI cancers in particular and other cancers are at very high risk for developing blood clots. So I've tended to very much avoid that use of that in my practice. The question of marijuana, THC, cannabis, cannabinoids, I think is a very interesting question. There is an agent that is kind of a synthetic target that has similar targets to marijuana, something called Marinol, that has been used in clinical trials. It is shown to increase weight, but not necessarily a lot of lean mass or muscle, or result in significant improvements in survival or function. Some feel like actual medical marijuana using THC would be more effective. There have been challenges in testing medical marijuana in clinical trials. So we don't know the answer of how well these things will work. Myself, as well as many others I know, are very interested as this becomes more regular use, over the next 10 years, of fully investigating this in the right way in clinical trials to know if it really helps or not.
Perfect. And I think over the last couple of years, there have been some clinical trials published with this new ghrelin agonist, which is an appetite stimulant and perhaps has led to some weight gain in some trials, maybe 1 to 2 kilograms, which is not a small number for patients who are actually, their trajectory of weight is actually downwards. So what are the challenges in getting some of these drugs approved and into the market?
So, you'll notice that during our conversation, one of the highlights for me is really at how this condition can affect someone's function or physical performance. So although this condition is characterized by weight loss and muscle wasting, we know that that's important, but that doesn't tell the whole story. So it's the whole clinical picture of loss of weight and muscle and loss of function, poor survival. So governing bodies like the FDA that approve medications for use are not just looking at gains in weight, because we know that if somebody gains a couple pounds, that might not really affect them that much. It might not affect their day-to-day life. So they want to see improvements in in weight or muscle mass, along with improvements of either physical performance, some sort of measure of function, or overall survival. the drug that the class of drugs that you alluded to is actually works on the kind of the hormonal system. It tries to augment a hormone that's released that triggers us wanting to eat. And so there's a lot of good science behind it in animal studies and smaller clinical trials that it has helped people gain lean body mass. And it led to a very large clinical trial of over 1,800 patients with lung cancer. And ultimately, it improved lean body mass over placebo, over getting just usual care. But it did not improve any sort of physical performance. And so it ultimately did not get approved by the FDA. In Europe, there may be different criteria, and so you might see drugs for cachexia used that may not be available in the United States. There are many to think that these types of drugs that may work on neuropeptides or hormones that are involved in eating and mass may be useful, although we have really been yet to prove how effective they are. So, we're left with not a lot of drug treatments or what we would call pharmacologic treatments for this condition.
Perfect. And just to wrap up, where do you see this field going in the next 5-10 years, and anything you expect to happen if we were to re-record this webinar in 2 years' time?
I'm optimistic. I'm an eternal optimist. I don't know if that's good or bad, but with things like this webinar, I have seen an increase in interest in this field, more recognition. There are studies being funded by things like by bodies like the NIH and the National Cancer Institute that are realizing that this is an important problem. Patients with cancer are living longer, which is great. And we want to make sure that that time that we're getting from new cancer treatments, that results in good, happy time for patients, that they're able to do the things that they want to do. So I'm optimistic given the recognition of cachexia and all of the research that's going on. Where I really see the field going in terms of interventions, because in the end, that's what's the most important part, in addition to learning all the science, is a multimodal approach. And what I mean by that is trying to hit several different targets. So I see very much exercise or physical activity as part of that intervention, a nutritional component, whether that be frequent monitoring by a dietitian or some sort of nutritional supplementation, along with some sort of pharmacologic drug that hits either targets of inflammation or targets that might help us with our appetite and restore lean body mass. And so I think what we've seen over decades of clinical trials is that one of these things alone has not really been enough to move the needle. And so I think you'll see more trials that are beautifully designed that incorporate multiple different types of intervention. It's a big effort, but I think that's really what the field needs and what people recognize.
Well, thank you so much, Dr. Dunne, and I'm an optimist like you and hope to have you here in the next edition of the GRACE Supportive Care webinar series. Thank you.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, and Takeda. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.